Hello everyone, my name is Weston Khisa. I work at the Kenyatta National Hospital in Kenya as a fistula surgeon. Today, I would like to present about correlates of fistula healing in East Africa. Many of you, I'm sure, understand what a vesicovaginal fistula is. It's an abnormal communication between a urinary bladder and the vagina of a woman. This is a very common condition in East Africa, even though we do not understand the exact prevalence. We see over about 1,000 cases in Kenya, and only about 7.5 get repaired. So we still have a big number of women waiting for repair. Some of the predisposing factors that we see in our case is usually early sexual debut, early marriages, and towards cultural practices that present or put this woman at risk of developing obstructed labor and hence culminating into a vesicovaginal fistula. Fistula affects very young girls, women with a very poor education who are unemployed, and usually during their first pregnancy. As you know, the cause of a fistula usually is a prolonged obstructed labor. In 90% of our cases, this is what we see. However, a few cases we see are as a result of traumatic injury during surgeries, as well as cancer and its treatment. To make a diagnosis of a fistula, usually you'll have in the history, what is significant mainly is a difficult labor. A woman who has had difficult labor, she's leaking urine continuously. And if you perform a dye test, that can easily confirm the diagnosis. And these women are likely to be dehydrated. They are likely to appear unkempt, usually have a bad smell, and may have a foot drop. Fistula, as you know, can be classified into type 1 fistulas, and these fistulas are not involved in the closing mechanism. Type 2 would involve the closing mechanism, while type 3 are other kind of fistulas that we see. In the management, many of them can be helped through surgery. However, conservative measures can also be very useful in the early stages of fistula formation. Consequences of fistula, these women will continuously leak urine. They may have a bad smell. They appear dehydrated, may have excoriations around their private areas, and they may have lost their periods. These women lose self-esteem because of loss of role identity. They get depressed, they get divorced, they are stigmatized, and socially withdrawn. The aim of this study was to come up with some factors that can help us predict a surgical success, even before you start the surgery. As you know, in literature, many of the factors that have always predicted success of surgery have many fistula characteristics. So we went ahead to establish whether there was any truth in this or not. So this major study was a mixed method. However, today we'll look at mainly the prospective part of that study, because we have presented elsewhere what we found in the qualitative arm of this study. Data was collected in all the East African countries, including Kenya, Tanzania, Uganda, Southern Sudan, DRC Congo, Somalia, as well as Malawi. What are the findings? Where we found that, okay, in general, many of the patients were from Kenya, and followed by Uganda, then Rwanda, DRC Congo, and Somalia. The age group ranged between 18 and 27, and that was a common presenting age, and the majority of the patients were unemployed, and most of them were peasant farmers and housewives, as well as running a small business. The majority of the patients we found who had leaked urine for at least a year, and these were the majority, followed by at least 2 years, and it continued to reduce with time. We found a few group of women who had leaked urine for more than 5 years. The commonest fistula that you come across is what we describe as type 2AA fistula. And these are fistulas that involve the closing mechanism, may not involve the urethra. And however, a few cases were also present, as is shown by the pie chart. The fistula size, the mean fistula size we found was about 2 centimeters, about 1 to 2 centimeters away from the external urethral orifice. And only about 22.4% had had surgery before and had lived with the fistula for up to about 12 months. A few, again, cases had vaginal stenosis, and others had combined fistulas with a rectovaginal fistula in about 3.3%. The mean success rate in this study came to about 94.1%. We used Kenya as a referral point to see how the other countries were related. And when this was done, we saw the referral in the multivariate analysis. We saw the referral as the point of referral or the country of referral coming out as a very significant factor in the success of a fistula surgery. Other reasons to explain success was unemployment, followed by a presence of a relative and vaginal stenosis, in that order. But the presence of a relative reduced the odds of a successful surgery by about 50%, while the presence of a skilled birth attendant was not very important as a point of success of repair. When we analyzed the data, we found some of the things that we can learn as preventive strategies were that we should involve men in terms of fistula prevention and care, because even after you have repaired these women, it was not enough for her to be able to reintegrate in the society spontaneously, except when women are involved. And of course, that we need to improve our healthcare providers' knowledge, as well as educate the women, the young girls, to go to school. Then they have a better way of making decisions for themselves without having to refer to the relatives around. The conclusions we came to in this study were that the country of referral was a significant factor, and that women coming from other countries to Kenya to seek fistula services were necessary. It was necessary for them to be referred to a fistula expert, or otherwise they are likely not to succeed. And unemployment, followed by unemployment, presence of a relative during childbirth, and vaginal stenosis. These factors help us come up with a model to help identify these women early enough if we have to improve our chances of success at surgery.